Okay, I'm going to hand the microphone over to the guy who is the basis of a lot of this work, did a lot of this work, Dr. John Harris, one of our founding board members and one of the vitiligo heroes of the past century. So John, you're going to introduce the panel and we're going to have some presentations and get started.
Thanks, Hilt. I'm happy to introduce the first panel. We tried this a couple of years ago in person at the AAD, and it was incredibly useful for me. We presented one of our cases that we thought was quite difficult and got a lot of feedback from the experts. And so I think this is a lot of fun and a great opportunity for us where we present our toughest cases. And I do this anyway. A lot of the people on here know that I text everybody when I get a tough case and have a hard time figuring out what's going on. So we should be able to use each other and learn from each other. And so here's one of those opportunities. So we have three panel participants. We shuffled the panels a little bit. So for panel one, we're going to have Dr. Ammar Ahmed, who's an associate professor and director of the Vitiligo Clinic. I love to see when there are vitiligo clinics. We need to have more and more of these. People are always asking me from all over the country, where can I see a vitiligo expert? And so hopefully we'll inspire some of the younger trainees to open these up as well. So Dr. Ahmed, thanks for joining us. Also the residency program director at UT Austin. And I imagine yesterday was a very busy and exciting day for you since it was match day for all of us in the US. And so the second panelist will be Dr. Richard Huggins, who is at Henry Ford, division head of Ford Road Medical Center in the Department of Dermatology, and vitiligo guru. You're growing them. I think it's unfair that Detroit gets so many vitiligo experts. So you're going to have to, as you train more, you're going to have to distribute them more, I think, to be fair. And then Dr. Victor Huang is going to be entering on panel one. We pulled him from panel two, put him onto panel one. Assistant professor and director of the Vitiligo Clinic and Phototherapy. Again, another vitiligo clinic, which is great. We were sad, the East Coast was sad to lose Dr. Huang to California. I'm guessing that you have warmer weather there, Victor, and I guess we can't blame you. At UC Davis, Department of Dermatology. And so I will stop talking and let you experts start talking about a case.
Great. So we're going to have Anna Parang, a physician, present the first two cases. And these are in more in the medical category. And then we'll have the second case will be more of a surgical category. So Anna, are you on?
I don't see Wyatt. That she's, I'm happy to.
Okay, go ahead and get started, Wyatt.
Okay, so I'm Wyatt Boothby-Shoemaker. I am a medical student research fellow at Henry Ford, and it's a pleasure to be here and honored with this panel. And thank you for giving time today to discuss these cases. So I'll jump right in and introduce the participants first. So our first panelist is Dr. Ammar Ahmed, and from the University of Texas, Austin, and second panelist is Dr. Maggie Ahmed from University of Massachusetts Medical School, and third panelist is Dr. Richard Huggins from Henry Ford Health System. And just going to our case study number one. So we have a 48-year-old African-American male initially presented in 2014 with hypopigmented patches on the scalp, thought to be related to seborrheic dermatitis based on biopsies. The lesions did not respond to treatment for seborrheic dermatitis and gradually spread to the face, trunk, and extremities. He has a past medical history of atopic dermatitis, asthma, and allergies. And there's no family history of vitiligo or autoimmune disease. And here we go to our physical examination. We're looking at the face and the scalp. And again, he was presented initially thought to be seborrheic dermatitis. Now, there's body images. We see some of those scattered hypopigmented patches discussed. And a view of the legs as well. And as far as past treatments, so he had ketoconazole, some treatments for seborrheic dermatitis, also some immunosuppressants there, and then also tried some different lasers and narrowband UVB as well. And currently, he's taking HelioCare twice a day, tacrolimus to the affected areas, home light therapy to the scalp, and then ruxolitinib topically to the scalp.
And just to clarify, Dr. Victor Wang, and Dr. Amar Ahmed and Dr. Richard Huggins are on the panel. So we made a little switch, if you don't mind. So go ahead, guys.
Thank you.
What? You tried too many things. This is unfair. Yeah, everything's already been tried. I'll go ahead and start. And I'm no expert in hyperchromic vitiligo. I could count on 2 or 3 fingers the number that I've seen so far. I think that we hold a debt of gratitude to some of our European colleagues. I think Dr. Ezzedine and Dr. Passeron kind of led the team, but it was also some investigators from Senegal and the Middle East that published that article in 2014 or so, that put out the biggest series that I've seen of this hyperchromic vitiligo. And I think it's gone by different names before too. And so I think, that's what this is, looking at it with the scalp involvement and the little white macules in the seborrheic areas of the face, and then a few scattered ones. It seems to go with the couple patients that I've seen, and the ones that have been published in the literature as well. I personally haven't had a ton of success at treating these patients, and I think if you look at that larger case series that's been published, it's difficult, which is surprising because there is oftentimes only a partial defect in the melanocyte destruction. So I guess a couple questions I would have, if Wyatt, if you happen to know the answers, is specifically in the biopsies, was there a decrease in melanocytes? Do we happen to know that? And also clinically, is there leukotrichia? Did this patient have leukotrichia, or did they have preservation of the pigment in the hairs? And then I would also wonder, how long has the patient been treated with the phototherapy in the dexamethasone? Those would be the initial questions I would go through my head when I think about how to approach this type of patient. So
no leukotrichia, and the biopsy was inconclusive. There seemed to be a reduction in some areas, but it's patchy, and it suggested vitiligo, but they didn't have enough of a specimen to compare the deep and pigmented areas, and we did 2 different specimens. So the absence of leukotrichia, that I believe in Dr. Ezzedine and Passeron's article, I think all of their patients had no leukotrichia as well, and still it is so difficult to treat. So I'll turn it over to Dr. Huggins and Dr. Wang and see what you guys think on this.
Yeah, I think this is actually very reminiscent of a case that John sent out to a bunch of us a little while ago. Agree 100%. This, in my experience, has been, in my limited experience with this particular entity, has been difficult to treat. But I think one of the first things that kind of comes to mind because of the unusual presentation is the diagnostic step, right? And so, this case has come from one of our excellent colleagues. So I have no doubt that the differential diagnosis and consideration of other entities has already been exhaustively explored. But amongst the most worrisome things in the differential is hypopigmented mycosis fungoides. You want to make sure that there's not any more pedestrian sort of explanations in terms of superficial fungal infections of the skin that can present with hypopigmented patches and whatnot. the discrete nature of the little spots on the torso make me feel actually a little bit better about the thing. But the sort of patchy nature of the areas on the back of the scalp are a little bit concerning for that hypopigmented MF presentation. And if a biopsy hasn't been done on the scalp, that might be a place to go, both because of that kind of funny morphology on the scalp, but the scalp also being a place of high yield for the diagnosis of mycosis fungoides from the pathologic evaluation perspective. From the therapeutic perspective, I'm afraid I don't have that much to add, except to say that the literature would support the idea that this is a very challenging condition to treat.
All right. So I guess I'm last.
Thanks, Dr. Egan.
Already been discussed in this very difficult case. So first, I'll go along the lines of what Victor was just discussing, in that if we consider an alternative diagnosis, one that would come to mind for me would be progressive macular hypomelanosis, which is typically more truncal, but could this not be an atypical case of that? And then considering the etiology of that condition, likely linked to the Propionibacterium acnes. And I wonder if that was considered in the treatment. I do see the patient was on minocycline, which can be used for vitiligo, but may have been used for that purpose. Do we go all out along treating that diagnosis? So combining the phototherapy with minocycline and adding on topical clindamycin solution and benzoyl peroxide wash and things of that nature, if we thought that that was a good possibility. But going with the diagnosis of hypomelanotic vitiligo, do we just be more aggressive with our treatment, knowing that this type of vitiligo is more resistant? And so I know he was already on oral mini pulse therapy at Henry Ford with Dr. Mzavi. At times when patients are resistant to that, we'll go to prednisone, initially starting with every alternate daily dosing. And in some patients, they've required daily dosing of prednisone. 20, I think, is the most typical dose we've used. Being a lot more aggressive, do we go with PUVA? Knowing that, that's not the preferred form of phototherapy, but we do know in resistant cases, where narrowband UVB is not effective, that can be helpful sometimes. A lot of potential side effects. Him being African-American, the skin cancer risk is a little bit lower. And then lastly, on the heels of Brett King's presentation, being more aggressive, do we go from topical JAK inhibitors to oral? Especially, considering the experience he's had with really few side effects with that line with oral JAK inhibitors. But those are all the thoughts I have. Definitely a really challenging case.
And so we want to give a lifeline access to the panelists. So we want this to be a conversation, because you're up and coming leaders and are doing so much work, but you have the right to call somebody and get some help on these cases. So please feel free. And we got another maybe 4 minutes left.
I had a quick question just in terms of like the physical exam and this question of the progressive macular hypopigmentation. I wonder if there was any hints that there might be that P. acnes involvement under the Woods lab exam, whether you saw any follicular coral red fluorescence at all that might have pointed us in that direction.
We checked the torso very carefully, and we didn't find any. And this is a case that Dr. Kundu at Northwestern University and I have been co-managing. And but yeah, we both checked and we didn't find any.
So the cases of PMH that I generally see, progressive macular hypomelanosis, usually in my experience have been more confluent. Even when I've seen them kind of in the earlier stages, lower back, flanks, they've been a little fuzzy and a little confluent. I haven't, when I was talking to my residents the other day, and I was like, fuzzy and faint. That's what I think of for progressive macular hypomelanosis. One other thing that popped to my mind could be PLC, pityriasis lichenoides chronica. I feel like that can be tricky as well. And sometimes finding those little inflammatory papules can be very difficult in my experience. And sometimes you biopsy and it's just PIH, and even clinically, like 95% of their spots can just be PIH. So I would, if I was approached with this type of patient, I would probably also really look carefully, make sure there's no little kind of red or reddish brown papules, it mixed within that too. And if so, I think a biopsy would be useful. One other thought could be, are there two things? Could this guy have PIH from seborrheic dermatitis on the scalp, and then also some post-inflammatory hypopigmentation from PLC or from some other little, weird papular dermatitis or something like that? Because the scalp doesn't really look like pityriasis lichenoides chronica. So there could be something else going on. Now, at the end of the day, I personally think this is hyperchromic vitiligo. I think that this matches up well enough with what's been reported with my own very limited experience that this is probably a case of that. But I 100% agree with, what my colleagues have said, that thinking about these other things is critical.
I wonder, just in the interest of bringing in some of the other experts that are available, Dr. Harris, the patient that you shared with us previously was quite different from this, a younger person, a little bit of a different morphology. But I wonder your broader experience with these hypochromic or hypopigmented types of cases, whether you've had any success with particular treatment modalities.
All right, so I wasn't going to say anything, but I hate the term hypochromic vitiligo. So, if we're going to use the term vitiligo, it should mean vitiligo. It should mean that it's an autoimmune disease destroying melanocytes, and I don't think that's what the pathophysiology is here at all. And so I would beg everyone to please change that name. I've begged Khaled, and he agrees at this point. I think when you first describe a disease, it's not surprising that we would call it something and then maybe need to readjust as we learn more and more about it. But sorry, that doesn't help at all. It's just a complaint about the term. So it's hard. I think hypochromic vitiligo is a form of macular hypomelanosis, progressive macular hypomelanosis. Its distribution is odd, right? It shouldn't be on the scalp, but it's much closer to PMH than it is vitiligo. UVB usually does a great job with most hypochromic diseases, whether it's CTCL or PMH or vitiligo, which is truly depigmented. And so why this hasn't been responsive, it's difficult to know. I think, I'm more thinking from the perspective of pathogenesis. If I'm going to think of options to treat rather than just throwing everything that has ever been used, trying to understand what's causing it. And it sounds like there's a decreased number of melanocytes, but no, inflammatory infiltrate, et cetera. So, I just said a bunch of things that doesn't help at all. And you might expect that because I sent a case like this to everybody. I think that the biggest feedback from everybody was concern for CTCL. And so we're pursuing that. We did another biopsy, which showed no CTCL. We'll do another one in a year just to make sure. But my case is responding really well to UVB. And I think that's most often the case.
And just to thank you, John. Also to draw from Nada Elbolek's experience with this, I think she has a series of patients that she has experience with from her time at NYU. Do you have any insights in terms of therapeutic options for us?
Yeah, so I think you guys answered this really in an excellent way, and I agree with everything you guys have said. These are really challenging cases, and I think the reality is we don't know what this entity is. I think, it was called hypochromic vitiligo, but as Dr. Harris just said, we actually think this may not even be vitiligo at this point, and it may be a new entity that we are still needing to characterize. And so we had 7 patients that I saw while I was in New York with almost an identical presentation to this one and the ones that Dr. Azzedine published in his initial case series. And then when Dr. Harris had sent out that email, we all started talking about collecting our cases to publish an even broader case series, which we're working on right now. The reality is that none of us have found any particular treatment to be successful in isolation. We can't say use this and this works. I mean, I do think phototherapy is helpful, but in combination with a lot of things. So when I've had these patients, I've literally put them on treatments for sort of the differential things that we've thought about. I agree with multiple biopsies as well. But I have tried, as Dr. Huggins was saying, adding benzoyl peroxide and clindamycin with the phototherapy as if we were treating PMH. But also you can add in some of the things that we use for vitiligo and seborrheic dermatitis, which are topical and sort of harmless to do in conjunction with the phototherapy. But I think we need to understand more about the pathogenesis of the condition, really figure out what are we actually dealing with here, and whether the word vitiligo should even be in there at all.
Can I ask a question to Dr. Elbaluk and Dr. Harris? In your all's experience, have you seen decrease in melanocyte number on biopsy if any of these lesions have been biopsied? And then also, have you seen a correlation with family history of vitiligo or family history of autoimmune diseases? Because I know in Dr. Ezedine's cohort, he reported that there was similar levels of family history of vitiligo, family history of autoimmune disease as in seen in just patients with non-segmental vitiligo, which would argue the opposite side of the coin, that maybe it is a type of vitiligo. So I'd be curious to know your all's experience with that.
Yeah, that's a good question. Our patients did not across the board have family history of vitiligo. One of my patients did have a family history of lupus, but there wasn't a consistent family history that I could say ran across the board with all patients. And with regards to the biopsy, that's what's so tricky about it. Similar to the one that Dr. Hamzavi mentioned, the biopsies are often sort of this mixed picture of, sometimes normal number of melanocytes, sometimes partial reduction. And so oftentimes, if you send it to the pathologist without really giving them much clinical information, it comes back with sort of a reduction in melanin, and that this could either be progressive macular hypomelanosis or PIH. I've never had them come back saying that this may be vitiligo. But yeah, I think that's part of the challenge, is that the biopsy can sometimes have this mixed picture, which makes it a little bit unclear. But it does not seem to overwhelmingly have absence or decrease in melanocytes across the board.
I have not.
Oh, sorry, go ahead.
Just to continue to answer, I have not seen a correlation with vitiligo and family history or anything else. Harvey asked a good question. How do we account for hypopigmentation in trichrome vitiligo? And so that's a good question, right? You do see hypopigmentation there, and trichrome vitiligo is really rapidly progressing. And so what I think is happening in trichrome is that melanocytes are being killed so fast, and the lesion is spreading so fast that the hypochromic area is absent in melanocytes, but the melanin is still retained in the keratinocytes. And so you're kind of still seeing some remnant of pigmentation because the keratinocytes haven't fully turned over yet. If you biopsy those areas, and we did this in collaboration with Amit Pandya, I don't think we've ever published this, but we did a very long biopsy across the depigmented, hypopigmented, and normally pigmented area in a trichrome lesion. And what we saw was exactly that. There was no Fontana-Masson negative, melanocyte number negative. Then we saw Fontana-Masson positive, melanocyte negative. And then we saw Fontana positive, melanocyte positive. So that hypochromic area, I don't think is the same pathogenesis as this. And the point I would make is because in vitiligo, you always have some depigmented area. I think that's the difference. Here, it's fully hypochromic and you never get fully depigmented. I think Ilt disagrees with me, and I don't want to speak for him. I think Ilt thinks this could be on a spectrum, right? And this could eventually evolve into vitiligo. And I suppose it's possible that you could have autoimmunity, destruction of melanocytes. The melanocytes are regrowing as fast as you destroy them, or almost as fast as you destroy them. And therefore, the melanocytes are fighting back and doing an okay job. In that case, you could imagine there would be a reduced number, reduced pigment, but no full depigmentation. And that's just not what I favor, but I don't know, it could be right. And that's why we need to study this.
Right. I think it could also be a dysfunction. Sorry, go ahead.
I was just going to say that Jean Bologna actually published a bunch of years ago a case of pentachrome vitiligo, and did a similar histologic analysis and found very similar findings in that case report. But I think it kind of points out the importance in these cases of atypical presentations or atypical patterns for that grabbing a biopsy of the normally pigmented skin for the pathologist to be able to compare to the hypopigmented or hyperchromic areas will be helpful for them to give us the most information coming back.
Great. Well, we want to keep the cases going, and we have another 20 minutes left. I'm sorry, 15 minutes left before we go to the abstracts. So I wanted to introduce the next part of the panel. So we're going to have all 6 of you here for the second case, kind of expanded medical management, and the last case has more of a surgical case. And so I'm going to introduce our additional panels because this is tough stuff. We're going to get some help for everybody. So first off, I wanted to introduce Maggie Ahmed, who is from the University of Massachusetts Medical School, has also a board certification in dermatology from Egypt, as well as a postdoctoral fellowship with John Harris, and she'll be joining us. We've got Nada El-Bullock, who is a clinical associate professor of dermatology at the Keck School of Medicine at the University of Southern California, also been actively engaged in this conversation. And then we have Tasneem Mohammed, who is also from Henry Ford. I'm apologizing we stacked so many people, but we are a very Detroit-loving organization. So I want to add them on board. We'll continue to have a little bit of a joint panel. I'm going to go through this next case very, very quickly so that we have some time for conversation. So Wyatt, go ahead and get into that one, please.
Okay, so for the second case, and just try to advance the slide. Here we are. So we have a 73-year-old South Asian Indian female with history of hypothyroidism, last seen on 4/26/16, who presents for continued management of generalized vitiligo with a body surface area of about 5%. Longstanding vitiligo, which has proven therapeutically challenging in light of numerous therapeutic modalities. Past treatments include some topicals, also ketoconazole and Selsun Blue, T-Cell. Again, similarly, did some steroid treatment, and then also looks like some laser treatment, and then narrowband UVB as well. And here's a more narrowed past treatment. So excimer laser therapy and narrowband UVB 3 times weekly, plus dexamethasone 4 milligrams on the weekends, where it was stabilized and then discontinued due to COVID. And I'm sure there's maybe a whole sub-discussion opportunity right there. Also took topical corticosteroids, Dovanox and Protopic, and then minocycline, 100 milligrams daily. And then currently restarted on narrowband UVB and pulse dose dexamethasone, and also on tacrolimus 0.1% ointment once to twice daily to the affected areas on the forearms and hands. MKTP procedure history. So in 2009, had MKTP to the neck, hands, wrists, and face. 2014 to the right hand and right foot. April 2015, left dorsal hand, ventral wrist, forearm, and elbow. And October 2015, right ventral wrist. And we have some pictures coming up here to show the before and after of those. All right. And then, so we have the before and after of the third MKTP there. So the top picture is the before, and then the bottom picture is the after. And so if we could, yeah, go ahead.
I don't know if it was time for us to discuss yet.
Yeah.
I think that there is some time to discuss, a few minutes.
Yep. So I think go ahead. So again, this is a case of MKTP and then recurrences. So please.
I was just curious for the panel, like based on the images here, would you guys consider this as a failed MKTP? I kind of, when I bring this up to my patients, I kind of suggest that, you know, complete repigmentation is of course like the goal, but is not always the case. And it looks like at least on this elbow, she's gotten some good repigmentation. There is not the best color match, but the expectation is that over time, or the hope is that over time, that will settle out a little bit.
Yeah, I think this patient actually had a really good response to MKTP. And again, the color match isn't perfect, but it is something that usually improves with time. I think the issue that this patient is having, which we counsel a lot of our patients on, is that once you get pigment back, you're not necessarily guaranteed to keep it. And so what it seems like happened here is this patient had an excellent response and then her vitiligo reactivated. So I think, you know, now it's just kind of making sure that she's stabilized. And I think she's on a lot of good treatments for that. But I think those could be further optimized a little bit. I know in the setting of COVID, there have been questions about, you know, whether it's okay to use steroids, but hopefully now that people are getting vaccinated, I think she could possibly, you know, benefit from some prednisone instead of just the pulse dexamethasone. And then once she is more stable, maybe, you know, be transitioned to pulse dexamethasone and then maybe back to minocycline. And then the other thing I noticed is that her doses of phototherapy were a little on the low side. And I'm not sure if that's whether she was, you know, because she was photosensitive or for another reason, but I think that could be pushed a little bit too.
I agree. I think, well, one confusion, I agree with Dr. Wong. My first thought was I wouldn't call this a failure based on the photos, unless these photos are flipped and the bottom photo is right after MKTP and the top photo is what she looks like now. And then I can understand that she's had some regression and loss of pigment. One of the things I noticed is that she's on tacrolimus with the phototherapy. And I think for vitiligo on the body, I think there's data also as well to support this. Class 1 topical steroids can sort of be more efficacious in treating these vitiligo patches in combination with phototherapy than the tacrolimus, which I tend to prefer to use on face and genital and intertriginous areas. The other thing too are that, we talk about vitamins and antioxidants that can help with disease stabilization. And I don't think I saw vitamins on her list. And so I usually like to give vitamin C, E, and alpha lipoic acid based on the work by Dr. Picardo and his group, and having trained under Dr. Pandya as well, who has been using that in his patients. So that may be an additional thing that can help with stabilizing her disease. And then the other thing is that she has a history of thyroid disease. And I always screen my patients at the initial visits, but I always do make sure that they are getting followed up with by endocrinology and that their thyroid disease is adequately managed and treated. Because there have been some case reports that show once you are sufficiently or appropriately treating the thyroid disease or other associated autoimmune disease, it can actually help in their ability to respond successfully for their vitiligo treatment. And I've seen that anecdotally in a few patients myself. So I think that would be another thing to consider in her. And then the last thing, of course, the hot topic of the day is the JAK inhibitors, which I don't think she's been on that, but you could always consider that if everything else is not working sufficiently.
Yeah, and I think the dynamic nature of how she of her vitiligo does kind of beg the question of whether she is stable enough to pursue sort of surgical options to kind of begin with, and I think it begs the real salient question of like, how do we define stability in our patients? And a lot of good work is going on to try to identify meaningful biomarkers for us to be able to address that in a more objective fashion. But we know that like patient self-report often is unreliable. And in the absence of having good photos to be able to go back to or documenting the extent of disease over time, it can be a really hard challenge to define that stability. I know that some groups have kind of advocated for doing little test spots, doing a small mini punch graft or something along those lines to see if the type of results that you get before proceeding with broader sort of surgical interventions. But I think that's a big consideration if the issue is she's continuing to get recurrences of her vitiligo over time.
One of the challenges with this case is that pretty much her image occurs every 3 to 6 years. So we do the MKTP, she's desperately depressed about it, and she keeps it for 3-4 years, and then it recurs, and then we do it again. So maybe Maggie, you've done so much work on this. Can you give us some immunology, and when do we do these cases? Do we give up every time, or do we prep, or what are your thoughts?
So we never give up. We do have enough evidences now based on a couple of studies we have done in our institution that suppressing the immune system can play a role to increase the success of repigmentation and also increase the durability of the response following MKTP. And when we are talking about suppressing the immune system, it doesn't have to be systemically. So even though if there's concern about using systemic corticosteroids because of COVID and a lot of other concerns, we can totally go with just topical immunosuppressive on the lesions together with phototherapy. Phototherapy is one of the best locally immunosuppressive therapy that we know in dermatology. Suppress the T cells infiltrate of the epidermis, which is technically all what we are looking for here. In our institution so far, we adopted a policy based on our studies that we are looking to publish soon that whoever is a candidate for a surgery, even though if they're reported, self-reported, as Dr. Huang mentioned, stability really well, despite of that, we put them on immunosuppressive, which is topical, tacrolimus, and or whatever we can get for that patient. Tacrolimus is usually our best to go. There's steroid and there's JAK inhibitors as well, together with phototherapy. And this is something that we are showing in our studies. Usually we started before the procedure and we continue that 6 to 12 months following the procedure. In our institution so far, we have seen 2 relapsing MKTP patients. And both of them were non-segmental vitiligo patients. So I haven't seen so far any relapse in segmental vitiligo, although we are showing in our studies as well that the immune cellular infiltrate could be there in both. So do not trust any stable vitiligo you are seeing. If you can put the patient in any topical immunosuppressive, at least for 6 months following the procedure, I would say that the response will be better and faster in comparison to none.
And then, so we'll take on one more question from the chat group, and then we'll go to the third case. And the audience was wondering, what are your thoughts of PUVA when narrowband's not working with these cases?
So PUVA, for me, we do think usually that PUVA is having like great effect, but the matching of the repigmentation is not the best. So narrowband is usually having, for us, it's been working really well, as Dr. Harris mentioned, and our institution has been working really well. And the color match of the repigmenting spots with the surrounding skin is usually better. So who's ever coming to us on PUVA usually have darker repigmentation, and we don't need to go deeper anyway with the wavelength. Like the wavelength of the narrowband UVB is perfect for the depth of the epidermis, and that's exactly where we want to go. I'm not sure if anyone else has more experience with PUVA.
I would say, I don't know if in this particular case, and I'm not sure if the PUVA question was referring to this case, but it doesn't seem like the patient has as much of a problem with repigmentation as much as there's the issue with maintenance of the pigmentation that they get after surgery. And so I don't know if switching them to PUVA would be appropriate in this case. But one more thing that I would say on the heels of those speaking about the importance of trying to maintain stability and the difficulty in this patient is that there is some data that methotrexate can be used to achieve stabilization. And then in a patient that you don't want to keep them on oral mini pulse or any other kind of corticosteroid therapy long-term, and maybe minocycline is not effective enough, methotrexate may be something that we can lean on. And we have obviously a lot of experience with that with our psoriasis populations.
We'll continue on that question of stability. Wyatt's got about maybe 2 slides if you can present, and we'll finish up. And that is a question. It's a question about stability and how to manage that. So Wyatt, do you want to finish up the last set of presentations?
All right, yes. So the third case, we have a 31-year-old South Asian male with generalized vitiligo, 10 to 15% in body surface area with onset more than 10 years ago. He responds to oral dexamethasone, but recurrences are frequent when the medication is discontinued. And besides steroid treatment, he's on a mix of topical medication, phototherapy, and supplements. This is the overview of the case. Physical exam. So here are some pictures of before and after the dexamethasone treatments started and were ended. So he had 2 courses of dexamethasone treatment. We just go back to the pictures real quick. Okay. There's an opportunity to look at the to look at those. And then past treatments were topical tacrolimus, 0.1%, steroids, and ginkgo biloba alpha lipoic acid, and then oral prednisone. He takes NB-UVB and the excimer laser as well, and also tried topical tofacitinib, but was discontinued after 3 months of ineffectiveness. And yeah, all right. And so we just wanted to discuss the management of this patient who responds well to dexamethasone treatment and repigments, but then ultimately depigments when dexamethasone stops.